Broadcasting on Spice FM. Nairobi 94.4. If you're in Eldoret, you're 96.7 or Nakuru 96.0. Go to Kisumu and the environs 102.5. Go to Malindi and Kilifi 97.7. Nyeri and Mount Kenya region 90.9. And where haven't I said? I've said everywhere. Nakuru and the environs 96.0. We're also live on KTN Home, and I'd like to say a very good morning to the audience on KTN Home, joining us from now until 9 o'clock. And also streaming online, Spice FM KE, YouTube, Facebook, and Twitter. CT Muga. As we begin this hour, please tell us today's proverb.
A person who does not lie shall never marry. It's almost like saying, if you don't want to marry, keep telling the truth.
Tell the truth and you'll never get anybody who likes you. People hate the truth.
Well, we'll look at it perhaps a little closer and in greater details at the end of the show.
Okay. So a man who does not lie will never marry.
Shall.
Is shall here
Shall or
a
must?
must, or is shall may, or
Will not. Shall here is a will not.
will not?
You just keep telling the truth and see how far you go with it.
Definitive.
When it relates to matters of marriage.
Yeah. Okay. So the president yesterday hosted the COVID-19 conference at the KICC. Various speakers from various arms of government and other stakeholders came together to discuss the country's work in the fight against COVID-19 since earlier in the year and what has been achieved so far, what has worked, what has not worked. There were various speakers who were saying, look, let's look at the positives. There are very many positives that we've seen coming out of this fight against COVID-19, what COVID-19 has taught us as Kenyans. And also looking at the final address by the president, who says, well, some of the measures that we took immediately and how quick we were to take those measures is what has led us to where we are right now, where we are still not out of the woods yet. In fact, we are at a dangerous point where if we just slacken, then we could fall back. But we are seeing that together we have gotten to a point we can resume some of our old normal, but in a new way. For example, reopening of the bars, increasing the number of people who can now attend church service and other gatherings, looking at the number of people who can now also attend funerals and looking at the protocols for funerals and all that, and how then we live our lives as a society, and saying, but we must always remain vigilant and careful. Is this largely what you expected to hear from the president yesterday, CT?
Actually, yes, it is. It is because it was, if I recall, what we've been discussing in the show has been a cautious approach to this matter of opening up the economy. Well, but with an emphasis that the issue of opening up schools was perhaps a little premature because we were actually not ready to open the schools as has been suggested, given all the things that needed to be in place before the safety of the children could be guaranteed. But as for the other things, yes, it is cautious, it is gradual. Give curfew 2 hours more. It's reasonable. Open up bars. Now, again, the media has been full of just the number of job fatalities that have occurred as a result of COVID. People who are in that industry, how they have actually suffered. Now, when you hear that the number of people who are allowed to probably congregate has increased, it means that even people who are allowed to perhaps the number that the hospitality industry can accommodate will also increase. Now, it is, in my mind, a positive change. And it is in a positive approach. Yes, it is. It is. There's one clause that I particularly loved, and I'm paraphrasing it, where he says, the president said, you know something, if we look and we see that things aren't going as we had thought, we will simply shut down again. That's me paraphrasing. Yes, we will shut down. So it isn't as though what we have allowed is supposed to just carry on ad infinitum. There's a provision that we are adding onto it, a little proviso. Should this happen, then we'll see. That, to me, is a responsible statement of saying we are not going to stop watching and looking and determining what is the best way forward. Yes.
I do think that it was consolidated in terms of effort to make sure they came at these decisions that they did. I also look at an element of listening to what the heartbeat of the country is at the moment. And I'd like to look at that from the point that a lot of people were really affected when it came to the economic effects of COVID. Opening up to allow a lot of people to get back to work. I'm not going to look at it from an entertainment purely point of view, where restaurants and bars serving up alcoholic beverages, and that's what people are looking forward to. But the point that people were able to then get back to work. I mean, we spoke to a chef yesterday, and what did he say? Look, if he opens up today on Monday, I can start earning again, you know, as immediate as that. And if these things are allowed, then we can get back to at least putting some dignity, not just back into our hands, putting food on the table. And that was then absolutely necessary for that to see happen. Taking all of that into consideration while not throwing caution to the wind, to understand that this is still something that could come. And also just looking at what he did say at the very beginning, he said, look, we can look at and say that certain milestones we have been able to reach, but that doesn't mean that because we seem to have achieved some kind of victory that we can then now throw up our hands in rejoicing and forget there's still a lot of work that needs to be done. And I think that was one of the overarching messages that came out. And then looking from the medical point of view, there's still danger that's lurking. There's still danger that's lying there. So even as, you know, things are loosened a little bit, we still need to make sure that we take care.
The danger didn't actually lessen.
It's still there.
Still there. What lessens it is what we do, the precautionary measures that we take. That's what lessens it. Yes.
I see this, and I'm sitting there joining everybody else who's celebrating. But at the back of my mind, I'm asking myself: are we where we are because of what the government and the people of Kenya did, or are we where we are because some mighty power has just landed us where we are? Look, so the president, for example, says. The COVID-19 positivity rate has fallen from 13% in June, 7% in August, and is now at 4.4% in September. That positivity rate dropping from 13% in June to 7% in August to 4.4% in September. Is it as a result of efforts that have been taken by the government, by the people, that you can then say that, you know what was happening in June, something was put in place, it reduced the positivity rate to 7%, and those measures continued, and they have therefore dropped the positivity rate to 4.4% in September.
What
is
was
that?
done?
What is that magic?
I don't see that magic, to be honest. And I think I said it, and so maybe I bored you guys sometimes, but I don't think you cannot compare the amount of testing that was being done 3 months ago to what is being done now. You can't. I mean, there's a huge difference there. For you to then be able to say this is what the footprint looks like, more testing needed to have been done. And I say that I think there's quite a number of people who are walking around in the population who are COVID positive, but by virtue of the fact that they've not been tested, there's no way for you to know. So then for you to say that, we've dropped a certain number of percentage points, it's okay. However, I don't see this magic wand that has been waved to say this exactly is what has been done. You told us, Eric, people are walking around with, what did we say? Head masks and chin masks?
Chin masks,
people are
forehead masks.
People were all over the place over the weekend. Others were arrested, I don't know, doing what. Everybody was out anyway. So is it something, or maybe the intervention of a higher power that you talk about so that people are actually not falling off the face of the earth and dying, right? But have there been particular interventions that have been made? Have you been able to find lower numbers because you're just not testing?
Because you're not testing.
No, but ask yourself the simple question. If you look at the figures, out of every 100,000, say, if you look at the America, not the Americas, America, USA, 395 per 100,000. Europe, 243 per 100,000. Africa, 16
per 100,000.
100,000.
Yes, cumulatively.
Continent.
16. So, when you're talking figures and you're asking how it is, the prevalence is what it is, then what really are you basing this particular statement on when you say, of course, the numbers are down?
Of course.
But then the other indicators, aside from testing, that we must look at. Do we have a situation where our hospitals are reporting that they're being overrun by cases?
Yeah.
We don't hear it. Are the facilities that we set in place being overrun by people? No.
We don't hear
so
it.
it may be true. There may be indication that indeed,
It's been managed.
yes.
But was
The
there ever a
positivity-
case where the hospitals in Kenya were run over?
There was a time when
There was
they were,
time when
they
there
were
was
busy.
questions like, okay, they were busy.
Yes, they were busy, and there were signs that they might get busy to the point where they are really chock-a-block being busy
Unable to.
to manage.
To
yes.
manage.
Yes.
Let's bring in Dr. Mercy Korir, KTN's medical journalist. Good morning, Mercy. Yes, now you're on air now. Good morning, Mercy.
Good morning, Eric. Good morning, City. Good morning, Ndu.
Good morning, Mercy.
Yes.
So, Mercy, you attended this conference yesterday. In fact, you
I did.
moderated some of the sessions
Yes. On the
and-
health response.
on the health response. Now, from where you sit, having covered the response to COVID-19 from the very beginning up to now, how would you answer that question? I'm sitting here and we are just asking ourselves, this positivity rate that's dropping, is it because our health system and our government efforts have actually brought it down, and of course also the citizens have brought it down, or is it because of something that we really can't explain?
Okay. All right. So for me, the honest answer is I don't know what exactly our positivity rate is. Because for you to actually have a proper indication of the positivity rate that gives a true picture of the country, you need to have more testing done. So it means I think you need to have 1 in 1,000 people tested so that you're able to, be able to say out of, let's say, 5 million Nairobians, we have tested 5,000 people. And out of these 5,000 people in Nairobi, so many have the disease, and so this is our positivity rate. Then you would be more confident to say this is a positivity rate. But if we see where we are now, we are not testing as much. Our testing is not even representative of the population, because now our testing is limited to people who are symptomatic, who are showing up in hospital, and people who need testing for other reasons, especially traveling. So if you look at the sample size of who you're testing, then your positivity rate that is there is not really representative of what is actually happening on the ground. And it's like what you guys have been saying. Like, there could be so many people who have COVID, but we don't know. Because look at our statistics. 93% of Kenyans who had the infection have not had any symptoms.
Yes.
So the three of you there could have as well gotten COVID, gotten over it, and life continued. So we don't really know the true prevalence of the disease in the country because of the fact that people are asymptomatic. And then two, because we are not testing as much, they're not able to pick out everyone. And granted, we cannot test as much as we would have wanted to, because it would be a waste of resources. Like initially, when now we were quote unquote doing mass testing, going to
various hotspots.
Exactly, and just testing everyone. That was not really useful because you needed to have targeted testing because of the meager resources that we have. That said, now going by the statistics that are there, the analysis that now our positivity rate is less than the 5% that is recommended by WHO, we have actually come down. Analyzing just that on paper, it's a mix of several issues. It's not that the government did only or the people did only. It's everyone who did their part. That masks were mandatory while in public, and at some point, everyone was keen on wearing masks. Physical distancing was encouraged. So from our matatus to when people are in lifts, people are observing physical distance, when people are told only 15 people can attend funerals, weddings, all of those things, when they are put in place, people followed and adhered to them. We closed churches and mosques and other places of religious worship. We banned other events, entertainment jobs. So all of those things, government did their part, then Wananchi did their part of following. So all of that was a concerted effort.
Did it really?
So as manage, our numbers.
I'm thinking about this practically, Dr. Mercy. If you look at the behavior, let's leave alone the government. So the government said, wear face masks. The government said, and even put it in law and regulation that you must wear face masks. You need to observe physical distancing. All business premises had to ensure this. Public transport had to ensure this. The people themselves, if you look at the behavior of the people in June, the behavior of the same people in July, in August, in September, for it to be dropping, you'll be saying that the people are actually observing those measures more strictly. I want to argue that it's actually the opposite. The behavior of the people now in September, when we are at 4.4%, is actually worse than when we were at 13%.
That's why my statement was, at some point, people were observing all of those things, and it worked. And my own theory, this is not necessarily what is happening. My own theory is that, one, by the time this disease was getting here, the virus was not as lethal as we expected.
Yeah.
And then two, we still don't know why that the disease has not ravaged Africa the way it did. And Dr. Umbaji yesterday was saying, it could be a population. Maybe there's something about how we eat, what we do. Considering Africa, most of the time we are out open places. Even in our houses, we do not have AC. We don't have limited, ventilation.
Yeah.
So all of those things could have played a part. But my own personal theory is that considering how widespread community transmission was at some point, it's possible that many people got infected because our population was asymptomatic for a better part of the time. It is still asymptomatic, 93%. It means that out of every 10 people that got COVID, only one person showed symptoms. The rest really didn't have anything. They probably did not even know that they had contracted COVID.
Yeah.
So you get the virus, you get over it, you develop immunity, and so even right now, if the virus is still around, people have developed sufficient immunity not to contract the virus again. Though there have been a report of a reinfection, but that was just one incident. So that is my own personal theory that we could have gotten this disease when it was at peak in week 27 in around July.
Right.
Because week 26, 27, 28, that was the peak according to the Ministry of Health graph. So it probably the disease around that time. Now we have immunity.
Okay.
So that could explain what we are seeing now.
So now with the theories that are coming out in terms of explanation as to why we don't have these mass infections in Africa, number one, then we're also looking and saying that the behavior in terms of protection, wearing of masks, etc., and then also saying that the numbers have dropped, then can't we then say that indeed it has been managed properly in this country, in other countries? Many have asked, to give the example of Tanzania, for example, you don't hear stories of people having dropped off, the face of the earth, dying from COVID. So isn't it then possible to say the numbers have dropped, whether you're testing with mass numbers or not, the numbers have actually dropped, and then it's okay to go ahead with, the measures that we have seen?
No, I agree with you, and I think also our numbers will continue dropping. And this is why we are moving, or rather we are going into a warmer, let me call it warmer season. And we know that the coronavirus thrives in cooler temperatures. The West is going towards winter, starting November, December. Whereas guys are going towards a warmer time. So we'll probably not see any more numbers. even if they are there, it's going to be just the few cases that we are still reporting, which for me is a good thing for Africa and a good thing for Kenya. The other thing is that we, as Africa, as African countries, we are the ones who got the disease last. And what I said earlier is that I think the disease followed the economic development pattern. When you look at the East to Europe to Americas, and finally it landed in Africa. By the time it was getting to us, we had seen what was happening. We were able to institute some of these measures quite early, restricting flights up to banning them. We were able to institute containment measures, isolation, quarantine, the hand washing. We were able to do all of those things early on, closing schools. We did them early. We didn't do them well. Obviously, it had many, many issues. But at least we did not wait for things to really get so bad for us to do that. What all of those things did was not to prevent the infection, but to spread out the days of the infection. And that's why you guys were discussing about our hospitals were not overwhelmed. They got busy. There's a time they got very many patients, and there's a time they were really getting very many sick patients. But they did not get to a point where now people are out in the corridors of the hospitals, or they are stranded the way we saw in the West. Because what we have done is sort of spread out how the infections would affect us. So we didn't flatten the curve. We just prolonged how the infections were affecting us to give us time to respond. Obviously, all of those things also had their own challenges.
Mercy, let me ask you this question. This is it is something that isn't discussed often enough, but I want your thoughts on it. The African immune system and the supposed robustness of it and its contribution to the limited proliferation of the COVID on this continent. What say you?
So this is very pedestrian. It's not based on any science. But looking at the African population, just from what we eat, we are more likely to be eating organic food. I mean, during COVID, people from the village were sending food stuff from, this long distance buses like Easy Coach. It was busy because people were sending in food stuff from the village to people in Nairobi.
Yep.
So if you look at how we eat, much as there is urbanization, we have all our fast foods around, we are still very basic with what we eat compared to people in the West. Our food is organic. We do not have as many GMO food as the West. So you find that our immunity is from even before COVID has been doing fairly okay. We have, and I usually like giving this example, we have very many communicable diseases, especially cholera, amoeba, and all of these things. They usually, in any one time in a hospital, you see somebody with one of those infectious diseases. So they are always here. But you never hear mass deaths because, there's been
an outbreak of cholera.
An outbreak of yes. Okay, cholera, when it was an outbreak, it kills people, many.
Yes, it does.
But there's not been like an alarming something out of the norm, So I think by the time we were getting into COVID, our bodies already are used to the diets we have. Our immunity is already good enough. It gave us some fighting chance. The other one is that our population, actually the young population works for us. So on average between 20 and 30 years. These are people who are at their best.
Yeah.
They are energetic. They are unlikely to have other pre-existing conditions like diabetes, hypertension. They are unlikely because those diseases tend to come towards, 50, 60, 70 years of age. So these people are likely to be healthy, and that is the bulk of our population. So it is a mix of all of these things that I think worked in favor of Kenya, worked in favor of many African countries, and then now add on to those other containment measures, which we tried to institute pretty early with their failures, yes, but at least it brought us something. And even when you come down to Kenya itself, Nairobi, for example, is very different from the villages. I don't know if anyone of you has managed to go out of Nairobi, but you find that people outside Nairobi actually are going about their lives. If you go with a mask to my village, then people actually wonder why you are wearing a mask.
They know you come from the city.
Where there's corona, but in the village there's none. And if you look at what happens in the village, people don't stay in the house. When the sun is up, you're actually out, and you're out the whole day until later when you now come, the sun is gone down, now you need to go and sleep.
So we need to take a break now.
This is the Situation Room, the only way to start your day.
On the line is Standard Group's Group Editor for Health and Science, Dr. Mercy Korir, and we are looking at the announcement made by the President yesterday following the COVID-19 conference. Uhuru reopens the economy. He warned against laxity, and we're looking at how the country has basically handled COVID-19 since the announcement of the first case. In fact, before the announcement of the first case for COVID-19, the establishment of the National Emergency Response Committee, the establishment of the task force, all the measures that were taken before that, all the measures that have been taken, during this period of COVID-19, and up to getting to a point where we are saying that the positivity rate for COVID-19 in the month of September is at 4.4%. And because we've hit that level where the WHO has advised, once you hit a level below 5%, then you can start looking at easing of some of these containment measures, then we are already doing very well. And the conversation that we're having is regarding this now, where we are at, the measures that we have taken, the vigilance that we need to deploy and still employ as a country. I am pushing, not pushing, I'm putting out an argument this morning that we as a country, as a government and as a people may be creating some false narrative of ourselves and saying that, you know what, because of the measures that we took in place, because of these measures that we've taken, we have been able to bring our positivity rate down. We've been able to address the impact of COVID-19. We are now at a positivity rate of 4.4%, dropping down from 13% just 3 months ago. That is not a mean feat. And we are patting ourselves in the back and saying that this is the work of our government and our hands. And I'm saying absolute nonsense.
You've forgotten the narrative that it may be the work of the Almighty.
That's actually my narrative.
Okay, spiritual intervention.
Oh yes.
But Daktari, because we often say that, and you've said on several occasions that decisions must be fueled by information, and the data that you get is what then should form these decisions, right? That's where you get this information from. If we look at the months of June, July, August, September, what kind of testing was taking place? And I'm still going to stick on the testing because for me, it's one of the only ways you can really know what's present in the country or not. If you want to look at countries around the world, India, for example, that's recording high numbers of tests, or rather of positive cases on a daily basis. But then look at their testing. They've done millions. In terms of testing, that's how they are able to know. The United States, 7 million cases, but they've done millions of tests. That's how they are also able to know. We look at countries like Mexico and Brazil that are suffering, right now, and are almost not able to handle things. But how do they know? They're testing. So can we really say, segueing off of what Eric is saying, Dr. Korir, can we truly say that with the information at hand, or that which agencies have been able to employ, that the state of things as is being reported is a true reflection of what's happening?
That's what I'm saying. We don't know. The only way, and you said it quite right, if you don't look for it, you won't find it, or you won't know that it's not there. And the only way to be able to know whether there's coronavirus in the country or not is through testing. So if your testing is not enough, if your testing is not representative of the population, you'll not be able to know. So I think for me, the conversation then should move to, since we are not able to do the antigen testing, since we are not able to do the diagnostic testing to say, you have presence of coronavirus, then we should move to antibody testing, because now this one it will be able to give you a better picture of who in the population had been affected by COVID-19, and now they have developed antibodies. Remember, in June, we published a story. Well, the scientists said it was our reporting in media was not really correct, because it said 2.6 million Kenyans by then had been affected by coronavirus, when now KEMRI, Wellcome Trust, and some other medics looked at blood that had been donated in various parts of the country, and they did antibody testing so that they could be able to work out the number of people who had probably been infected by that time. So anyway, our own crude estimates from the media was about 2.6 million. Of 2.6 million Kenyans by that time had been exposed to the virus. That was June. So we need more of those tests, because now they would be able to tell us, in Nairobi, out of 5 million people that are in Nairobi during the day, we see that 3 million of them had been exposed to the virus. That would be more useful information to the Ministry of Health, to the President, now to be able to say, okay, it looks like now 60% of the population have gotten the virus, so people have immunity, we can actually go back to our lives. But without that data, if we are still waiting to test and get everyone who's gotten the virus, then we'll still continue doing the same thing we were doing in March, chasing after the virus. It will not tell us anything new. Not that the looking for the virus should stop. It should continue, because we still have people who are contracting the virus and they are vulnerable. They have pre-existing conditions. So those people still need to be catered for. We still need our hospitals, isolation centers to attend to them. Recently, I was able to go into one of them, and actually the people who have been admitted there with the virus are actually really sick, and they need critical care. So our taking care of people should be focused on, okay, those who get sick, we know they'll likely be very, very sick, and they'll need critical care.
And that they're able to
make
access
sure
it.
those are there. Exactly, and they're able to access. And at least now, I can say for sure, the medical teams are now confident. They know what they are doing. They know what they are handling, and people are actually getting much, much better care.
But are the facilities there? So
yes, they are there.
That anybody who really requires critical care is able to immediately access the critical care facility.
Yes, they are there. That's what I can, because I have seen it for myself.
Mercy, where exactly is this available?
So
which facilities?
Preempt my story that I'm working on.
Oh, okay. So why don't I change the question and ask something that has nothing to do with your story? There is on the 29th, which was yesterday. There was
Today.
29th.
Today.
Okay. This is Eric's fault.
The 28th day of 29th.
Yes.
Yesterday.
The Monday, which is actually Tuesday. Yes.
The first Tuesday of the week.
The first Tuesday of the week. Okay. And it's me asking the question, not
sorry.
Eric. Okay. There has been news of a rapid test that takes up to just 30 minutes before it appeared in The Guardian. It's something that is being talked about. WHO has even, according to the article that I read in The Guardian, given authorization for emergency treatment on one of those tests. I'm assuming you've also heard or read about it as I have.
I haven't come across it yet.
All right. Now, there has been that discussion, and it follows, in my mind, a similar progression that was made with HIV, because for the longest time, rapid testing was something that wasn't commonplace, neither was it affordable. Why I'm bringing this discussion is because our problem with testing has been test kits. It's going to be here next week. It's going to be here the week after. That week, 5 weeks ago, it's still the next week. Now, if a test kit such as this one, which is being touted as being inexpensive and readily available, and organizations like, say, Find, who they call that a new diagnostic Foundation for Innovative and New Diagnostics, who actually try to buy in bulk for third world countries like ours. If indeed this is available, would we then say that we might have a clearer picture of what our prevalence, what our positivity rate is? Because if it's cheaper, it's available, we'll definitely be able to test more people.
Definitely, especially if it is an antibody testing, if it's an antibody-based testing, the one I was talking about, where you're able to, because the rapid test in HIV is antibody-based. So if it's able to detect and do that initial screening and it's rapid, then you're able to actually know extent of the disease or the prevalence of the disease in the country. So for me, that would be a very welcome diagnostic tool to incorporate into the mix. But even as you incorporate antibody testing, this one for detecting COVID-19 is still very, very important, because even in HIV, when you do the antibody screening, if it's positive, if you have the two lines, yes, it's very most likely indicative, but we always advise have it confirmed. And now you go and check for the presence of the antigen, the HIV virus in the blood. So it will probably follow the same pattern. And because, and you've rightly said, because we have learned from HIV and other viral infections, we don't need to reinvent the wheel. We know how things have been moving, we know how things progress, so we can actually move faster. So that there is a rapid diagnostic kit that even WHO has okayed for emergency use means that we have just learned lessons very fast. Unfortunately, maybe not African countries as fast as you'd expect, but that we have learned and we are able to quickly move in order to contain the disease. So I think for me, that would be a very welcome kit. And even just throughout the COVID period in the last 6 months, there have been many other rapid diagnostic kits introduced. Some laboratories have had it, they have used it, but there had been controversies around it because of you're not very certain about the accuracy of these diagnostic kits. That's why everyone was still relying very heavily on the testing that we know, because now that testing identifies the presence of the virus as opposed to the antibodies. So all of these measures really play a critical role. There's no one route only, but I think it's several things coming in together.
But all those things, Mercy, as we speak about, all these other possible ways that we can improve our testing capacity, all these other methods that we can go into testing, there was also talk earlier of KEMRI also developing its own testing kits. How far did that go?
I know they got stuck in approvals because of you have to be really key on accuracy, that it's supposed to meet to pick a certain, I forget what the percentage was, but I think they're looking at it's supposed to pick, I think, more than 90% or detect more than 90% of the cases. So because you have to validate them. So if they are not picking, then that is not a test that you would deploy out in the public, because it means it would miss some cases. So you have to look at its accuracy.
So are they still working on it? Are they still continuing to fine-tune their development?
I don't know how far they are now. I've not followed up on that particular one.
You see, the point I'm driving at with that question is, even as we look at, there's other companies, other organizations out there that are working on rapid test kits or other methods of testing. and hoping that then that can be deployed in this country. I'm just peppering that with the reality. If we are not in our own making concrete and a lot of effort in developing that internally, and if we have not even made sufficient effort into increasing our own testing capacity, we have never tested 7,000 samples in a day.
And yet we've
Which
had
is
the capacity, by the way.
We have that capacity. We've had
We
it
have
for the
never
longest time.
tested 7,000 samples in a day in this country. So this whole talk of, there are others happening elsewhere in the world. The reality of it happening in this country. How you get what I'm asking?
Yes. So how I look at it, and maybe this is just the scientist in me looking at it, is who do we need to test? What do we need to test? In my opinion, who we need to test is that person who the identification of the virus will make the doctors or the medics develop a management plan, a treatment plan for them, or it is absolutely important for us to know that you have the virus or not. Now, if you're otherwise going about your day, you have no symptoms.
Yep.
Why do we need to test? We don't need to. So that's why I'm saying we need two-prong approach to our testing. So once you know who you want to test and why, then you're able to separate. So the person who you need to know if they have the virus or not, you categorize them. Those ones you'll just be needing to test in the hospital. People going for surgery, people who've come with symptoms. You do the antigen testing.
Yep.
Then for the rest of the population, the rest of us guys who are out here, what we need is the antibody-based testing.
And this,
The
what you're
testing
saying now, Dr. Mercy,
Yes.
you have said it before. Other scientists and other doctors and other people in the medical profession have said it many times. It hasn't been deployed.
No, so now you don't need to do it mass testing. So that's where I was getting to. You don't need to go and pitch camp and say now we are doing mass testing for antibody to check if you've had coronavirus or not. There are ways to it. And like the way the first study that Cambridge Wellcome did was to identify any presence of antibodies in blood samples. You can also now look for a representative sample of the population, and then you go out and pick out of them. If let's say, for example, you're saying you need to get 1 in every 1,000 person, then you do that sample collection. There should be a methodology to it, so that now you come back and say, from these studies that we've done throughout Kenya over this period of time, this is the prevalence, and so we think A, B, C, and D. But not pitching camp and saying, now we've done 7,000 tests. And the way we're doing it, for me, it was not really as useful as going into those details and getting the nitty-gritties of it.
Actually, what you're saying is actually happening. The process has begun, I think, probably towards the end of the year, or is it early next year? There is a center in Cambridge called Center for Respiratory Disease Control. They will be conducting the study similar to exactly what you've stated. And at the end of it, we will have a clearer picture of what the prevalence is. Yes.
Okay. So then we are moving in the right direction.
Yes.
And for scientists, they don't usually announce first until they get the results.
No,
Yeah.
they don't.
So then we're moving in the right direction.
Doctor, as wrap this up, I mean, just look and hear even all the things that were said yesterday. Is there still a danger? I mean, we've heard Dr. Moth talk about, a second wave of infections and the health system then not being able to carry. Is this danger real?
Okay, so I'm looking at how I'm looking at things is one, our population has had 9 in 10 people do not have any symptoms. So that's a good thing. So it means even if there's a second wave, we are likely to still see the same kind of picture. But two, what I am what I'm is it laying my hope on or
optimistic
about is that we are getting into warmer, hotter temperatures and a season where the virus does not really thrive. So I personally don't see us getting a second wave.
Okay.
And that's just from me. And having seen the pattern, so seeing the pattern in the West, seeing what we've had here, I do not see us getting a second wave. We'll probably just continue sustained infections in the vulnerable group, though you said. So those infections will still be there.
Okay.
But I don't foresee a situation where now we are overwhelmed. Two is that the way we are gradually opening and easing, and people are asking, why didn't the president just open up? Why do we still need a curfew? So you need to ease things slowly, such that by the time you're now fully opening, you have been gradually getting there. So you gradually reduce the curfew hours, you gradually increase the number of people in gatherings as you watch and see, so that whatever is happening, you have sort of a controlled, your numbers are within a certain level that you can control. Even if they spike, it is just minimal. You can be able to pick and bring it down immediately. So I do not foresee us getting into a phase where now we are crying, we are overwhelmed by everything that's happening.
Dr. Mercy Korir, we want to thank you very much for speaking to us this morning, shedding light on the fight against COVID-19. Of course, we hope to have you in the studio soon.
Hopefully, yes.
Yep.
And many people are telling me Corona imeisha. So we'll make it to studio next.
We'll see.
Asante sana. Dr. Mercy Korir is a group editor for health and science of the Standard Group.
The Situation Room, the only way to start your day.